So we'll start off the day with meniscal allograft transplantation. I'll go over the current state of the art, and then we'll go over future directions for meniscus surgery. This talk will touch on the anatomy of the meniscus. Most of you are probably already familiar with that. We'll go over the clinical problem of meniscus tears and meniscal insufficiency, how meniscal allograft transplantation can be a solution for these particular problems, especially in younger athletic people. I'll touch on the technique. I'm not going to go into too much depth, but then I'll also touch on what's in store in the future. So a lot of the people in the audience are already pretty familiar with the meniscus and its anatomy, but just to recap, there are two menisci in each knee, one on the inner, which is the medial side, and one on the outer, which is the lateral side. They're relatively C-shaped. They're sort of these wedge-shaped structures that sit between the femur and the tibia. And most of us think of them as the shock absorbers of the knee, because basically what they do is they distribute forces across the knee to really try and protect the cartilage. If you asked orthopedists 40, 50 years ago, they used to think they didn't do much. So unfortunately, people back then would have the majority of the meniscus taken out, and then they would develop, unfortunately, rapid arthritis. And really, that's what we're trying to prevent. The predominant direction of the fibers is radial and longitudinal, really longitudinally front to back. And that plays a role when we think about meniscal repairs. States here meniscal injuries are very common. And in fact, when we look at various orthopedic surgery practices, meniscus surgery is probably the most common procedure we do. Because really, as we age, the meniscus becomes more and more brittle, and it's a lot more prone to tearing. So a lot of people end up getting partial meniscectomies. The problem is when you have a meniscus injury, it disrupts those fibers that distribute the forces. And that, in effect, will increase the load on the cartilage on the femur and the tibia. And it can go up to 3 times the load that the cartilage will end up seeing. The cartilage, which is the cushion of the knee, is not really meant for those type of loads, and that's where degeneration can occur. And ultimately, when degeneration becomes bad enough, that's when you have arthritis, the loss of cartilage on both sides of a joint. And then patients will report pain, swelling, and stiffness. This is these are just some various types of meniscal tears, but these are simple tears. Most adults really develop what are called complex tears. So there are cracks in the meniscus. They go in multiple directions. And this is an arthroscopic image of what a meniscus tear looks like. So here's the femur, there's the tibia. The meniscus sits between the two, and you can see a flap tear here. So this is relatively common. What do we do when we're confronted with something like this? You have a young adult who had a previous ACL surgery. Mark, you're probably familiar with this case, actually. She re-injures her knee, and she ends up having a bucket handle meniscus tear. So you may have heard it, if you're in the OR, you may have heard of us talk about bucket handle meniscus tears. What that means is the rim of the meniscus is still intact, and then the bulk of the meniscus has been pushed out. Usually it ends up in the notch where the ACL and the PCL are. Now, unfortunately for someone like this who's had this problem for 2 to 3 months or longer, it's very difficult to pull the meniscus back down to here and then basically lay stitches across it and get it to heal. So unfortunately, this was an irreparable type tear, and what we do in effect is take out this meniscus. And in effect, the patient is left with this small rim, just a couple millimeters of meniscus, and the majority of the cartilage, as you can see here, is just rubbing up against the other side without anything in between. Now, if this patient comes to us 6 months to a year later and starts reporting persistent pain in the compartment where the meniscus is missing, and maybe even has effusions or swelling, that's when we sort of run up to a problem. What do we do here? Because we can get a sense already that the patient's knee is going downhill. Now, in these types of patients, meniscal allograft transplantation may be an option. Now, who's a good candidate for this type of procedure? If we had a room full of orthopedic surgeons who do this surgery, it could get a little controversial. Some people think that we should probably do it in everybody who's young and healthy and has an otherwise pretty good knee if they're missing a meniscus, even if they have no pain. I would argue that the patient should at least have some pain because this is a big procedure. They should be on the younger side. We can do this in people usually below 50. Usually, though, I end up seeing people under 40 because their cartilage tends to be in better shape. But you don't want them so young that they're still developing. So the 11-year-old who has a bad meniscus problem and still has open growth plates, we probably wouldn't do it for. They can't be stiff. They can't be too overweight. BMI is a tricky thing because you can have a bodybuilder who's over 30 or whatever it is. But in general, outcomes are better when the BMI is lower. And also the insurance just won't even reimburse if it's above a certain BMI. And finally, they really can't have arthritis because that's what we're trying to stave off. If they already have arthritis, unfortunately, it's too far gone. Now, for some of you in the room, you may dread when you see this case on the surgery schedule because I'll also probably add an osteotomy or an ACL with it, and sometimes we'll do a meniscus transplant ACL with an osteotomy where we cut the bone and realign it, and those procedures can take 3, 4, 5 hours. But those are the sort of things that you have to do if you're really going to try and preserve the patient's joint. You can't just put in a meniscus in someone who's already bow-legged and hope that the medial meniscus transplant is going to correct that problem because they're already starting to veer the way of arthritis, and we got to do everything possible to prevent that. What's a meniscus allograft look like? Well, this picture is exactly what it would look like when we get it shipped to us. The meniscus is attached to a piece of the tibia. It comes from the tissue bank. So it's a cadaver. It's basically someone who donated their organs, and it's stored in a fresh frozen manner. Now the problem is you have to be patient. If I have a young patient, say 21 years old, who has a meniscal insufficiency and we think we're going to do this, it can be a few months before we actually get the right meniscus because they have to be the exact size or really within a certain percentage. They have to be the right side, the correct side, and they have to be the correct meniscus. So it has to be, if it's a right medial meniscus that needs to be replaced, you have to get a right medial meniscus, and it has to be the appropriate size, and that can take a few months. So these aren't things that, happen the next day. I'll just touch briefly on the surgery itself. There are, a variety of ways of putting these meniscal transplants in. Usually on the inner side or the medial side, we do it a little bit differently than the lateral side. But this cartoon sort of goes over what we do. We trim the remaining meniscus. We'll drill 2 holes, one in the front, one in the back. That's where the meniscal roots will be. And then for the medial meniscus, usually what I'll do is I'll just take the meniscus itself with some bone plugs, cylinders really, attached to where the root is, and then you dunk those in the tunnels, and then you'll stitch the remaining meniscus. Other surgeons will do it where they don't even use the bone plugs, they'll just put the meniscus in, and sometimes they'll even take a bridge of bone that connects the 2 roots. That's really the more common way of doing the lateral meniscus, so you'll see us take the meniscus with a bridge of bone that connects the 2 horns. And then basically I'll create a slot in the tibia, you slide the meniscal transplant in, and there are a variety of ways of fixing it that way. It can either be a press fit, where you just put the bone, you slide it in, it's kind of tight, you tap it in and it'll stay in position, or you can use a screw to keep it in place. That's how I've been doing it lately. There are a variety of ways of doing it. What do we do post-op? So post-op, I'll put them in a hinge knee brace and crutches, usually for a minimum of 6 weeks. The first couple of weeks, I'll let them do touchdown weight bearing or toe touch weight bearing, and then advance to weight bearing as tolerated. I'll have them start bending and straightening the knee immediately. Usually they'll get most of their motion by about 4 to 6 weeks. But I don't like them bending the knee when they're weight bearing. It just puts too much shear as the femur pulls back when you're in flexion, too much shear on the meniscus. No rotation of the tibia. Usually they'll start jogging at about 3 to 6 months, and I'll clear them to 6 to 9 months. This is an actual still from a video of someone who had a meniscus transplant on YouTube, and he's demonstrating how he was rehabbing his knee. Basically, he was a skateboarder, and he would just go up and down these these sort of chain links. I wish I had the video, though. Anyway, what can you expect with this type of procedure? The downside to the data for meniscus transplants is because we don't do as much of it as, say, ACLs, there just isn't as much data. So there aren't randomized controlled trials or things like that. But we do have these meta-analyses where people will look at all the studies that are available and then come to some sort of conclusion. So these are the more recent things that I found. In the American Journal of Sports Medicine, which is probably the most prestigious sports medicine journal, this was an analysis of 9 studies. They looked at survivorship. So how many of these meniscus transplants are still viable? How many that were put in are still working and the patient hasn't had another surgery? Well, at the 5 to 10 year mark, the majority are still viable. The majority are still intact. They're 85% in the medial side, lateral side's almost 90. But unfortunately, once you get past 10 years, there's a precipitous drop. And this has been shown over and over. Dr. Noyes, who helped pioneer meniscus transplants and did a lot of work on it, he's in Cincinnati. His data is pretty much the same. Once you get to about 8, 10, 12 years, unfortunately, the meniscus seems to start breaking down, and people will unfortunately require other invasive procedures done. This is more for the surgeons. Another meta-analysis looking at fixation, because we debate, should you have some bone with the meniscus transplant? Should you just put the meniscus in without any bone? It doesn't seem to be any difference. And then these last two on the right side, on the right column, I put in because, again, it sort of emphasizes that meniscus transplant surgery works, but we have to sort of think of it as a last resort or a salvage technique. So Waterman and his group looked at a military group of patients, over several hundred, with a mean follow-up of 2 years. So pretty short term. Now, we look at the military and we look at the military data because these are the types of people that really put their knees and shoulders, etc., through the ringer. And if they can do well, then we suspect that the average person will. But we see that at 2 years, almost a quarter of them still can't return to military duty and had to be discharged. So it works, but to get it back to the level, the highest levels, it's very difficult. Zaffanini is an Italian, this was an Italian group that looked at their case series with a follow-up of about 4 years, and many of the patients can return to sport, so about 3/4 of them can return to sport, but really less than half return to the levels that they were playing at before they went downhill. So we have to look to the future. What can we do to really make this a better procedure? Now, the FDA is very good at trying to protect patients, but it also limits what we can do. So a lot of this stuff is not approved for the US. It's being done in Europe, Israel, and other areas. Scaffolds are one thing that people are experimenting with. So say someone has a bad meniscus tear. Usually it's in the back. Let's say I have to take out a portion of the meniscus like this. Well, then I can size a scaffold like this and just put it in. And this is what this image shows. This is the scaffold here where you can see the marks, and it gets stitched into position. This is looking from an aerial view down. You can see, you can see the stitches going across. So these scaffolds are basically synthetics that will either break down over time with the hope that the body's own cells will reconstitute the meniscus, or they may be non-degradable and they'll just sit there. But it's an alternative to taking out the entire meniscus. The data is somewhat iffy at the 5-year point. They're not perfect. We don't have great data. Most of it, again, is from, well, all of it is really international, so we don't know in terms of the US here yet. Now, the other thing that's pretty exciting, some of you may have heard or read about, say, in the New York Times or other forms of media, is an artificial meniscus. And there are only a couple centers in the US that are experimenting with it. This is not FDA approved either. This is really just sticking a hunk of plastic in the knee and hoping that it acts like a meniscus. So this is exactly what it looks like. It's polyurethane. And all we would do is make an incision right on the side of the knee that needs the meniscus, and you just jam it in. I mean, theoretically it should be a little more sophisticated and precise than that. But that's the reality. There's nothing that we use to keep it in place. You make an incision, you put it in, and you hope for the best, and we'll see what happens. I mean, this is something that's being experimented with, so you may hear about it, and who knows, maybe it will work. But right now, there's literally zero data on it. It's the only thing that's really out there that's an artificial meniscus. So we'll just see how it goes. And who knows, in a couple of years when we're having this conference, maybe I will present something that shows that it works, or maybe it doesn't. All right? Thank you.